Good afternoon. Welcome back to the Reimagining Behavioral Health, Race, Equity, and Social Justice Conference, presented by the Harborview Medical Center Behavioral Health Institute. We hope you took good care of yourself during the break and that you also took advantage of the networking opportunities. Remember, for assistance or additional information, please use your chat function. Now, I would like to welcome you to Addressing Trauma when Working with People Who Have Disability, presented by Dr. Elizabeth Scriven. Dr. Elizabeth Scriven is a licensed psychologist with Therapeutic Health Services in Washington State. She identifies as disabled and uses a wheelchair for mobility. Dr. Scriven has been a mental health therapist since 2012, serving in hospital rehabilitation, outpatient clinics, and community mental health. Before becoming a therapist, Dr. Scriven worked in therapeutic recreation and adaptive fitness. She is a passionate advocate for disability inclusion, accessibility, and education. Her current project, Voices of Disability Book Project, seeks to give those with disability the opportunity to share their disability experience through written word. And with that, I turn it over to you, Dr. Scriven.
Great. Thank you so much for having me today. I have been at this event at least a time or two in the past and have just loved it. So thank you for having me. Let me pull up here. So today I am wearing a brown sweater over a hot pink and brown shirt. And I have just slightly longer than shoulder length dark hair, and I'm wearing glasses. So we're going to talk about addressing trauma when working with people who have disability today. A bit about me before we get going. Like Danny said, I am a manual wheelchair user. I have been since I was about 18 months old. And so today you're kind of getting this 2-for-1 of the I'm ready to present as Dr. Elizabeth Scriven with some psychology background, some mental health background, and some, a deep dive into some of the literature. But I'm also Elizabeth, who has over 40 years of lived disability experience. And so I'm really hoping to be able to combine these two things with you today, and that you'll learn some of the stats and some of the frameworks we're going to be talking about, but you'll also get a piece of my lived experience as we talk about the things. Feel free to use the Q&A for questions, and we should have at least 10 minutes at the end for those is my hope. So what I'm hoping for today is that you'll be able to take away a bit of an idea of what ableism is, that you'll be able to name some impacts of ableism and recognize it when it happens, and have at least one new idea on how to support people with disability who have experienced the trauma of ableism. I'm assuming some of you have probably worked with people who have disability and chronic conditions. I'm also assuming that many of you work with folks who have diagnoses of various kinds from the DSM. Those themselves can qualify people as technically having a disability. And that's because with the American with Disabilities Act, they define disability as even just being regarded as having such an impairment. So a person who's maybe in remission from their mental health diagnosis or has a psychotic disorder or a bipolar that's really well managed could still be regarded as having an impairment due to their diagnosis. So that's a piece of the definition there. But the bigger piece is a physical or mental impairment that substantially limits one or more major life activity of such an individual or a record of such impairment. So when we're talking about major life activity impairments, we're talking about things that impact caring for oneself, performing manual tasks, seeing, hearing, eating, sleeping, walking. Bodily functions could be things like digestive processes, bowel and bladder processes, neurological brain function, respiratory, circulatory. So if folks have any impairments of these, according to the Americans with Disabilities Act, they could be defined as disabled. So just some general stats to put things in perspective. About 15% of the world's population is self-reports a disability. It's the largest minority group in the United States, with up to 27% of American adults having disabilities, and over 20% of children under the age of 18 have disability. Disability is a unique status because it intersects all other social identities, LGBTQIA+, BIPOC, religion, all of the things could intersect with a disability of some kind. You could be born into disability like I was, or you can acquire it later through an accident or a health impairment like cancers. Um, Another unique aspect is its solo status. So quite often in a family group or a social group, um, the person with the disability may be the only one with that disability and maybe the only one that they know that's disabled altogether. So for much of my growing up, I very much was solo status. I didn't know anybody else who had my birth defective spina bifida until I was, late elementary, early middle school. And that much of my adult life, I'm also a bit of a solo status, in different places. Um, as we start talking about disability more, there are some people that I work with today that do have disability, and that's been a pretty unique opportunity for me. Disability, trauma, and mental health. So when we think about trauma and mental health, um, lots of folks with disability have experienced traumatic events, and we know that there's a higher prevalent rate for depression, anxiety, especially in populations with disabilities. So 17.2% of children with a disability were the victim of violence or witnessed violence, whereas only about 5.3% of children without disabilities, so quite a few more. And 55.6% of adults with disabilities report mental distress, which is 5 times more often than their peer group. So the mental distress includes stress, depression, problems with emotions, different things like that. So ableism, the definition that we're going to be using today, is a set of beliefs, values, thoughts, and or behaviors that discriminate against people with physical, intellectual, or psychiatric disabilities. It can result in inaccessible environments, unhelpful attitudes, and untrue assumptions about people with disabilities that put unwarranted limits to those with disabilities across a variety of life domains. And my kind of perspective anymore is that experiencing ableism is traumatic. We'll talk later that I don't mean that all people with disabilities have PTSD, but when we run up against ableism, I think we often, or at least I often, respond from my trauma place, and can go into that fight, flight, freeze. So we'll talk a bit about that later, but a little bit more about me and why my ableism has been traumatic for me. So, like I said, I was born with spina bifida, got my first chair at 18 months, started doing sports in middle school in my racing chair, did track and cross country with a whole bunch of able-bodied peers. Started driving as soon as I turned 15 and a half. I was at the DMV that very day, started driver's ed the next day, and I've been driving ever since. I got my first job at a grocery store at 16 and really had to advocate to get a promotion. People were getting promoted all around me within 6 to 12 months, and it took me several years to get a promotion at the grocery store, but I did make it to cashier. I've went to college, lived in dorms, got a graduate degree, got jobs, got house, have pets. My dog is actually sleeping under my desk today. Um, and yet there's been a lot of tension too, because given society's opinion that people with disability don't do many of those things, there's a lot of imposter syndrome that goes along with doing things that don't match people's expectations for you. And if you've internalized those, it can be an even stronger impact. Um, One of the interesting things in my own experience is that until I started graduate school and started looking into these things a little bit more, I wasn't even really aware that I was impacted by these things. They all kind of go under the radar. They're a bit more covert than some of the other isms, and can even look good sometimes. And we'll talk about that in a little bit. So ableism in and models of disability themselves. Models of disability are important because it's how we contextualize and understand disability. So I'm just going to go over 4 models real briefly. The first is the medical model. It's been around the longest. The focus is on the anatomy and physiology of the individual, what works, what doesn't work. Experts or doctors diagnose and treat the issues. The disability is seen as existing within the individual, and therefore the individual tends to hold a higher level of responsibility for both the problem and the solution. So think treatment adherence. Ableism shows up all over this model. The deficiency-based model, where the question is, how severe is the disability? What can't the person do? Which is really quite interesting to me because I don't think we go around asking people how BIPOC they are, but we want to know how disabled somebody is. There can be a lot of trauma around having an unfixable status. So my disability is stable over time. It won't change. It should hopefully, knock on wood, won't get worse, but it's not going to get better either. So therefore it's unfixable. And then there's this risk of being over medicalized. So many people with disability are in and out of the medical system all the time. They need prescriptions for ongoing durable medical equipment or medications. Maybe they need a lot of procedures. I had a bunch of surgeries as a kid. And this over medicalization can really lead to beliefs that you are broken and you are deficient because you're talking about what's not working all the time. It can also really lead into beliefs about needing help or this idea of learned helplessness. People tend to overhelp a lot anyways when you have a disability. And so that can be an issue with over medicalization. The next model is the functional model of disability. You see this in a lot of rehab settings. And here it states there's a specific relationship between the individual, their impairments and body functions, and then the things they're encountering in the real world. Excuse me. And function is measured by the person's body, the impairment. So for me, my legs don't work. That's my impairment. And then what kind of durable medical equipment, devices, technologies can be used to kind of mediate and moderate the impact of the impairment. So I get along and get around just fine as long as I have access to my wheelchair. But if my wheelchair doesn't work, well, then I'm kind of stuck. And so I'm more disabled if my wheelchair is broken. I'm less disabled if my wheelchair is working. Ableism shows up all the time over here too, because it's related to the availability of assisted technology and adaptive equipment, and not just the availability, but the cost associated with that, and that person's ability to pay for the things that they need. The assumption here is I'm only okay if I can function, and it's still a deficits-based model. The social model of disability is a bit better, and it posits that individual people have impairments and that disability is caused when the people with the impairments interact with the barriers in the society that keep them from fully integrating. So things like environments. I need elevators. I need harder surfaces. Sand and gravel don't work well for me. Things like that. And then there's attitudes. So I need people to believe in me and think that I can do things and not paint me into corners. And policies. Policies around, paperwork that someone needs to be filled out. If I had quadriplegia and couldn't use my upper body, but I was supposed to sign forms, like that's an issue. To mitigate disabling factors requires social action. So rather than making it the person with the impairments job to change things and fix things, the social model says that society needs to take action. Ableism isn't absent from this model either. Ableism shows up in inaccessible environments, stigmas and attitudes, and discriminatory policies. There can be a lot of pushback and gaslighting, which can make it very difficult to get community involvement and change. And this can be really disempowering for the individuals with the impairments. It can also be a bit more difficult to integrate the disability into your identity if it's this thing that's outside of you and not a part of you. which can be challenging. A newer model of disability understands it as a minority. Very similar to how other marginalized groups are viewed. People with disability experience oppression and are othered, and can experience minority stress. Disability is defined as a social construct here too, where limitations are not related to the disability but the social construct, and thus are relatively unwarranted. This model is pretty cool because people with disability get to define the disability, its influence on their life, and can refuse the disabled role if they want to choose to do that. Um, Ableism is still alive and well. There are many myths of disability. There's external myths, and things around disability about what people with disability can and can't do. Internally, people can still internalize those and believe them. People may still get disempowered via the social barriers, things like policies causing red tape, people's attitudes, excuses like it's too expensive or it's not fair. If we do it for you, we'll have to do it for everybody, which can make this model can still be traumatizing for folks. So we're going to talk about ableism and systems. So ableism can show up in medical care. It can reinforce the internalization of brokenness. Like we talked about a minute ago, it's deficit-based. People want to know how severely disabled you are. The individual or family is often responsible for the solutions or adherence to treatment. This idea of if I'm impaired now, I will always be broken. Many quality of life measures, people with disability can't measure up. They want to know how well you access your environment, if there's difficulties with walking, seeing, hearing, things like that. And if you answer yes, then your quality of life measure can never be as high as has high of a rating as somebody without those things. There can be access issues around equitable care. So lack of roll-on scales. I've been working with Optum now a few years to get roll-on scales on all the Optum clinics. And if you're from the Pacific Northwest, you might know that Everett Clinic just got bought out by Optum. And so that's a really big deal. People need roll-on scales. Like we need to know whether our weight is changing. Accessible exam rooms and hospital rooms, accessible tables. There's a lot of folks who maybe can't transfer onto an x-ray table or an MRI table. Lots of times the doctor's offices rooms aren't set up to be super wheelchair friendly. There's often a lack of knowledge of the specific disabling conditions. So for example, mine is spina bifida, and it used to be considered a pediatric disorder. So there aren't a lot of adult doctors who know about spina bifida. And there can be difficulty getting preventative care. Some of it's access issues, but some of it is just doctors not realizing that a symptom that's being brought into the room is not disability related, but something else. And then there's a lot of trauma with this, right? A lot of medicalization, difficulty finding care, lots of regularly occurring medical procedures and hospitalizations for some folks. I've had, before the age of 18, I had 14 surgeries and over 20 hospitalizations, and there have been more since turning 18. And that's just me, and that's a relatively low number compared to some of the people I know. A lot of blaming symptoms on the disability or the impairment rather than medical conditions, and sometimes just lack of appropriate care in general. So disability by the numbers in medicine, and this is part of the problem in my opinion. Training programs, only about 7.6% of medical students have anonymously reported a disability, which is up from 2016, but only 2.5% of those have requested an accommodation. So how many of these are making it all the way through medical school? Folks who disclose having a disability on their applications to residency match have a lower percentage of matching. So 5.9% only reported it, and only 81 of those people got matched, opposed to 83% who don't report having disabilities. So it's, a 2% difference, which is big when you're thinking about residency programs and a discrepancy there. And then in the profession, only about 1 in 33 doctors report being disabled. And from what I read, most of those are like slightly older folks and probably have age-related issues that have caused impairment over time. Ableism shows up in medicine. So only about 50% of medical schools include disability curriculum. There's a whole bunch of barriers across all sorts of education programs to disclosing and obtaining accommodations, but in medical school too. Criteria for med school can be inherently exclusionary. So there's certain criteria that med schools are looking for that people with disability can't check the box for. Again, a lack of standardization and accommodation requests. This is really across all education programs. And then an inconsistency of those programs to be able to support the accommodation needs. In the profession, 82.4% of doctors report believing that people with disabilities have lower quality of life. 82.4% of doctors think that I have a lower quality of life just because of my disability. And this came up a lot during the COVID pandemic in discussions on who was getting ventilators and who wasn't. And there was a lot of fear involved in the disability community that people with disability weren't going to get the ventilators if they needed them due to their COVID diagnoses. And then 40.7% feel confident in their abilities to treat people. But that leaves 60% that don't feel confident in treating their people with disabilities. Dr. Okunlamunyi had a spinal cord injury during their residency. And one of their thoughts is that the reason there are so few doctors with disabilities is not because they're not qualified, but it's because they're waiting outside without a ramp just to get a seat at the table. So he's talking about the accessibility issues around medical schools. The guidelines for providing accommodations were also relatively new. They started in about 2018 and were revised in 2021. Now, mind you, the Americans with Disability Act was put out in 1990. So I think the medical world might have a little ways to go to providing some equal access to training. However, ableism shows up in behavioral health care as well. There's often a mismatch in psychologists' self-perceived competency and knowledge about working with people with disabilities and their actual measured competency and knowledge of working with people with disability. So similar to doctors, they just don't know how to work with people who have disabilities sometimes. Disability and ableism are super common, yet have received much less attention in research and training than other marginalized groups. You can go down the rabbit trail of looking at the impacts of isms on racism or sexism or any number of things and see a lot more research on other marginalized groups than you do to people with disability. There's a lot of access to care issues here as well. A lot of offices or facilities aren't wheelchair accessible, especially if you're in the private practice world. I remember looking for private practitioners before, and my first question was, is your office accessible? Do you have an elevator? Are you on a ground floor? Is there an accessible bathroom near your office? Access to education can be hard, and getting those accommodations. Treatment protocols are not designed with people with disabilities in mind. And so sometimes you do have to adapt what you're doing to fit the person and their impairment. Cost of care can be high. Until really recently, Medicare only covered psychologist level services and did not cover master's level counseling, which is a problem because a lot of folks who have disability are probably also on Medicare. And there can be denial of treatment due to high care needs. Folks with comorbidities for addiction or significant mental health who maybe need inpatient treatment can be denied due to high care needs. Maybe they need a aid, maybe they need some wheelchair accessibility or help transferring. And if that can't be provided at those inpatient facilities, their care gets denied. And then there's a high tendency for mental health symptoms to be separated from disability status. So your depression is over here, but your disability is over here and they're not touching. And so there's some trauma inherent in this, right? There's trauma in not being able to access the care you need, trauma in trying to work with a provider who doesn't understand your disability, trauma in working with somebody who tries to separate your mental health symptoms from your disability. This is in part is because of the lack of numbers of people with disability in the field of psychology. So a 2016 presentation noted that there were about 3% of students who identified as disabled, only about 2% of faculty, and about 1.4% of interns, which I find interesting. So something happens between the student level and the internship level where you lose half of your disabled students. Only about 2% of internship program supervisors identified as disabled, and only just over 4% of psychology health service providers in general identified as disabled. Some of this has to do with attitudes and barriers and discrimination that was reported as the largest barrier by a survey. 37% of respondents thought it was stigma, discrimination, and attitudes. Lack of accessibility was another big one. So how does ableism show up in the training and in the profession? Programs do not have to go beyond reasonable accommodation, and reasonable is a very subjective term. Students must self-disclose and know they need accommodations. So you have to be comfortable telling someone what's going on for you, and to do that, you almost really need to know that accommodations are even possible. And if you didn't have them before, maybe your disability is new, or maybe you went through undergrad okay, but now at this higher level, there's maybe some things that are coming up, and you need to know what to ask for. Students with disabilities do not need to be retained if the accommodation would alter the nature of the program or lower standards. So again, this is a relatively vague idea, and a lot of schools seem to be a little apprehensive about violating accreditation standards by providing some of the accommodations, and so it can be a tricky road to navigate. In the career, there tends to be a status, like a maintenance of the status quo. Like if it ain't broke, why fix it? I would argue it is broke, but if you have the privilege of being able-bodied, you may not see that. And because there's underrepresentation across academia and training sites and the profession, there's not a ton of voices inside saying, hey, we need to change things. Other issues have been with the APA convention, where they got rid of the word disability in their resource room at convention to the multi-abled room. Or this year, I went to the convention and it was just all sorts of accessibility issues around not enough elevators, not enough automatic doors, not enough single-use bathrooms. It was very loud, very bright, very spread out. So, if you had a sensory issue or a mobility issue, it was a difficult environment to navigate. In society, how does ableism show up in society? Ableism has a larger effect size than racism or sexism. It's less searched. You can look at the stats there on how often different things are searched, and it's down there at the bottom. So people just don't know it's a thing. I didn't have a word for ableism until a lot later in life. Access to activities can be limited. There's a lot of confusion around equality and equity. So equality is I'm going to give everyone the same thing, the same path to the desired outcome. Equity is I'm going to give you what you need to get to the desired outcome. And so a lot of times there's not equity in ability to access programming. Universal designs, which is a design principle that would make environments easier to use for people of all kinds, tend to be lacking. And then I like this idea of languaging as a verb. So when we are talking and speaking to people, it really kind of can hint back to the way we think about things, what we believe about things. And so to be intentional, I'm going to language as a verb and put some intentionality in that. And ableism shows up because we tend to use disability emphasis languaging, deaf, autistic, blind, handicapped. We tend to use deficit space quite a bit, can't walk, can't read, wheelchair bound, those kinds of things. And there's a ton of myths and stereotypes about disability. So the little picture on the slide there has all sorts of random questions that are based in those myths that people with disability tend to get. But there's myths about life, like such as people with disability are brave and courageous. People with disability are overcoming or compensating. Myths about working around people with disability are best suited to unskilled work. People with disability are less productive. There is actually research out there to say that people with disability tend to be more productive than their able-bodied peers. And the myths about relationships, such as non-disabled people are obligated to take care of people with disabilities, like we need taken care of. People with disabilities are asexual and can't have sexual relationships, and a whole plethora more. It's a never-ending list. So on the scene entered critical race theory not all that long ago. And now there's a lot of crossover between that and critical disability studies. And there's a wonderful book by Sammy Schlack called Black Disability Politics, where she really highlights the parallel between Black disability politics and social justice and civil rights movements with the disability social justice and civil rights movements. It's a fabulous book. It's a pretty easy read. Highly recommended if you haven't heard of it before. She looks at civil rights movements, feminism, disability rights, and speaks around colonialism, oppression, marginalization, silenced voices as really being the issues for all marginalized groups. She does a bunch of interviews at the end of her book, and Patty Byrne is another person. They identify as queer and disabled, and she states disability justice understands white supremacy and ableism as inextricably entwined, both forged in the crucible of colonial conquest and capital domination. She says ableism is very much one and the same with racism, because what we're really talking about is who has agency in our culture. I'm reading another book that she just did the foreword of and had some expanded on that, and that one's been really great too. And then you have T.L. Lewis. T.L. Lewis has a definition of ableism here on the screen that I'm just going to let you guys read. And T.L. Lewis also let's see, I'm looking at my notes. I lost my spot. So T.L. Lewis states, there is no ableism without racism. You quite literally can't have one without the other. There is an unbroken chain between asylums, plantations, zoos, circuses, and prisons. There needs to be understanding that it is all of the system of oppression that are operating simultaneously and the connected history of oppressed groups that are at the root. It is the understanding that these systems are mutually constructive that is needed to dismantle and decolonialize them. And I love these statements because it sets the stage to say that minority stress is the result of ableism for folks with disability. And there's a lot of research out there now about minority stress. Meyer defines it as the relationship between minority and dominant values and resultant conflict with the social environment experienced by minority group members. So, and with this idea of target and agent positions. And I love this because it fits my experience. I do not have PTSD. And when I am feeling painted into a corner or discriminated against in any number of ways, I certainly can act with a trauma response because of the chronic nature of the ableism I've experienced over my lifetime. Minority stress can lead to stigma, which is broadly defined as a social devaluation based on discrediting identity or differences. It tends to serve three functions: exploitation, social norm enforcement, and disease avoidance. It's not good, right? Like, and stigma, and if you believe in some of the stigma, leads to really intense discrimination at times. Discrimination can be group based, so based on someone's background and group identification. Policies that discriminate, so things like no wheels allowed in the guise of safety. I was once told I couldn't go on a hiking trail because no wheeled vehicles were allowed. That was not accurate. However, I didn't go on that trail that day. Um, Discrimination could also be perceived. So it's how a person with a disability might interpret a situation or another's behavior. And I think that one's really, really difficult. Um, Sometimes there was some discrimination in the form of a microaggression. Um, but sometimes somebody is right and maybe I shouldn't do something or couldn't do something. And it's not about the disability and about something else, but I can mix those up in my head if I'm not aware of what's going on. You have the fundamental attribution error, where thoughts and beliefs that lean on trait-based explanations without considering environmental or situational explanations. So the hike is a good example, right? Certainly people with disability don't hike. Therefore, the reason you don't see them on the trails is that people with disabilities can't or don't hike. But the truth is, you don't see me out on the trails because a lot of the trails aren't accessible. They're not flat, they're not wide, they're not whatever, and I can't take my wheelchair on them. Therefore, I don't go hiking. If you were to make those environments more wheelchair friendly, I might show up on them. I love hiking. It's one of my favorite things in the Pacific Northwest. There's disability spread. Disability spread is this idea put out by Beatrice Wright that says if this one part of you is disabled, certainly all of you must be disabled. This one gets really apparent when I'm out in public with someone who's not disabled or not apparently visually disabled, and a stranger is talking to us, having questions for me, but asking them of the person I'm with and not talking or asking them directly to me. Minority stress comes with health outcomes, psychological distress, negative health outcomes, and can have a really huge impact for individuals. And again, I'm not saying that all people with disability meet diagnostic criteria for PTSD, but I am saying we have all experienced ableism, and that in itself can cause this minority stress and trauma response. So the trauma of ableism is insidious and chronic. It comes in the form of microaggressions, so outgroup assumptions that determine how bad the life of the individual with a disability is, condescending and patronizing responses, or inspiration porn. So I was at a job once. I like to kayak. I haven't kayaked lately, but I used to drive around with the kayak on the top of my Subaru. It was easier to store that way with where I was living. And I was down in South Seattle. I live in the North End. Somebody asked me, how many buses does it take for you to get here? And I pointed out, you could see my car parked, outside the office window. And I said, see that car with the kayak on top? That's my car. I drove here. But that assumption that I took multiple buses to get to where I needed to get because I'm a wheelchair user is a microaggression. Gaslighting. So when something is made to feel like my fault when it's not, I get gaslit quite a bit when I decline help. I don't always want help. I don't always need help. Sometimes getting help is more tedious and time consuming than just doing something on my own. But people can get really bent out of shape if I decline, and make it feel like I'm doing something bad because I said no, thank you. Stereotype threat behaviors. These are behaviors that kind of go and support a stereotype. So underperformance, if someone doesn't think that I can do something, why should I even try? Avoidance of situations, I'm just not going to do that. Unhelpful defense strategies that limit development. So things like not succeeding to the level that they'll be able to. If I'm not supposed to take the test or pass the test, then I'm not even going to study, because why study if I'm not going to pass anyways? It's easier to know I didn't study and didn't pass than to try to study and try to take the test and then fail. And there's a lot of stress against guarding against stereotypes. And we know that chronic stress can cause cognitive function impairment, a decrease in reported well-being, and even have impacts for physical health. In my opinion, that's all traumatic, but the real trauma of ableism is internalized oppression. And internalized oppression is defined as an involuntary reaction to oppression, which originates outside one's group and which results in group members loathing themselves, disliking others in their group, and blaming themselves for the oppression, rather than realizing that these beliefs are constructed in them by oppressive socioeconomic political systems. So I hear all these things all the time, and I start internalizing them and believing them, even when they may not be true. For me, this is what led to the imposter syndrome I kind of started with today. So how does this all present? When your clients or your patients come to you, what does this trauma of ableism look like? Well, if you work in the mental health world, some of the problems you might see are depression, anxiety, or trauma response behaviors. Think emotional regulation difficulties. Um, you might see people that have maladaptive schemas. So when the external stigma is believed and applied to the self, it internalizes the stigma, and that becomes the lens through which people see themselves. So emotional regulation difficulties when triggered, that's a really common trauma response. Um, there's this idea of deteriorated self-concept. So someone just doesn't think of themselves as a full being, and lacks a sense of competence. There are going to be a lot of stress related to poor socio-occupational or educational functioning and income. So we talked about all the difficulties with school, and getting those accommodations. Those accommodations can be difficult for in the job setting as well. Or you have this kind of circular loop of maybe you're fine sometimes but have flare-ups other times. I have a really good friend who has this issue where they're completely able to work when they are doing well. And when their health issue pops up, they're flat on their back for several weeks at a time while it flares up and does its thing and then gets better again. And so they're not able to work consistently, which is an issue for a lot of jobs in general. But they're also dependent on government assisted medical insurance, which they can lose if they work too much. And so they're really stuck in this space of not really being able to work, not because of their disability at all or impairment, but because an employer doesn't want somebody who has to take a several weeks off at a time to heal. And if they work too much, they're going to lose the benefits they need for the medication and other things that they need to stay as healthy as possible. And there's also difficulties connecting with the disabled community. So there's, in general, fewer opportunities to connect, especially in person. I think during COVID, we saw a lot of new online groups for folks. So that's a good thing, and that offers some more connection, but it's not in person most of the time. There's this idea that people with disabilities shouldn't draw attention to each other by mixing, which can contribute to internalized stigma. There's also this idea of contamination and fear of contamination by, if I'm with other people, I might catch their disability and be more disabled myself. There's no truth to that, but it seems to be an underlying fear. If you work in physical medicine somewhere, you might see people coming in for cardiac issues. Like, so when I'm anxious, right, my heart races, or maybe I have panic attacks sometimes and my heart feels funny. GI and stomach issues, stress hormone can impact how well you digest food. Tension can cause pain and headaches. You see higher levels of substance use. This is a tricky one because some people with disability need controlled substances, but that doesn't mean they're taking them as prescribed. And sometimes it can be easy to overuse. Not that everybody does that. And then there might be just a general sense of malaise. I just don't feel well. I feel like things should feel better. Um, and so those are some things that you might see when people come to your office. All right, so that's a lot. Ableism is everywhere. It impacts us. But what can we as providers do? Well, the first thing we can do is check ourselves. What are our own biases? What do we think and believe about people with disability? What do we know is true? What can we kind of challenge and find space for alternative understandings around? What lenses do we see things through? Do you experience countertransference when working with people with disability? Maybe feelings of helplessness or hopelessness. Rescue fantasies about being able to fix them and make them better. Fears of your own mortality, or anxiety around body integrity. Those two are especially common if it's a terminal illness or if that disability was acquired during a traumatic event. I mean, really, we could all end up in a car accident on our way home today and not be the same tomorrow, right? So there could working with people with disabilities can bring up fears around mortality and anxiety about body integrity or losing control. There's a tool called the Able Privilege Inventory. It's a 23-item questionnaire that you can use to kind of assess your level of power and privilege and where you're at with these things. I can't show it to you because it's copyrighted, but you can find it if you Google it. And that can be an interesting tool to use yourself or maybe as a team. Basic counseling interventions work just as well, in my opinion, as people with disability, on people with disability. So you might want to use psychoed. Talk to them about the different models of disability. Talk to them about ableism and its impact, their intersectionality, the hermeneutics of disability, what impacts their belief, how does their belief impact the information and the people around them, and that interplay between the two. Use person first languaging, be intentional. So it's, it's the person with a disability, the wheelchair, the person who uses a wheelchair. Maybe they prefer identity first language. That's my preference. I like to be called disabled, capital D. The deaf community likes to be deaf, capital D. And folks on the autism spectrum have started owning the word autistic, capital A. So talk to them about their different options. Let them choose. You use strength-based languaging. Look at what they can do. Look what kinds of tools they might have at their fingertips to be able to help them navigate the world better rather than being deficits based. You can use CBT and CPT to identify maladaptive thoughts and beliefs and to work on those. Behavioral activation is great to encourage participation in different types of activities, maybe things they're kind of nervous about trying. Family systems can be hugely important. Most individuals are within the family system or maybe chosen family system. And those people in their life might need some support in helping that individual navigate the world and have healthy relationships. Narrative therapy to change the meaning of the historical story and restory the future. EMDR could be helpful when working with those who have speech impairments in particular. It's not as talk heavy as talk therapy. And so for those folks that might have difficulties with stuttering or maybe have some sort of an aphasia, might really benefit from EMDR. Some interventions in medicine. Do your homework. Learn a little about the disability and ask for clarification from your clients about how that disability or impairment impacts them. Be curious and genuine. Admit if you aren't sure if their symptoms that they're presenting with are disability related or maybe something else. Refer out to specific providers if necessary to help you kind of parse it out. And take the person's concerns seriously. If they think something is wrong, they know their bodies better than a new provider. And check things out. Then we can all be an ally, right? Because remembering like all of the common factors research, relationship is at the heart of any trauma therapy. So be genuine, actively listen, show empathy, adapt the approach you're using to fit the client. See the whole person, not just the disability. Don't make assumptions. Let the client tell their story. Validate. A little validation can go a long way. And be aware of your languaging and how you're speaking to them and where your frame of reference is. So again, I hope your takeaways, I hope that you're able to describe ableism. I hope that you're able to name an impact of ableism and recognize it when it is happening. And that you have at least one new idea about working with people who have disability and how to support them better in their healing. Any other takeaways, you can go ahead and stick them in the chat. My work cited, there's a bazillion of them. And questions or comments, you can email me, or you can check out my book project at voicesofdisabilitybookproject.com. I've expanded what I'm looking for, so I'm now looking for any autobiographical stories or art around the disability experience. And I would be happy to hear from you, or if you want to share my website with others. And I believe we have some time for questions.
Yes.
So let me stop sharing and hit me up with the questions.
I will. So, but first, let me just say, Dr. Scrim, this has been fantastic. Absolutely fantastic. As someone who teaches clinical mental health, this is like an amazing amount of energy that or information that we needed.
Great.
So
Well,
thank
and
you
I
so
will
much.
add, I am working on turning this into a 3-hour seminar that will meet the new health equity CE requirement in Washington State. I have a deadline now of November, so hopefully by 2025, I'll be able to offer seminars.
Okay, that's awesome. Here is your first question.
Sweet.
Do your stats and numbers of disabled people include non-physical disabilities, such as mental health, neurological, such as autism and ADHD?
So that's all census and mostly census information, I believe. And so it is all self-reported, and it is whatever, and Centers for Disease. They also have some stats. So it's all self-reported survey stuff. It is supposed to include all of it. But it's self-reported. I think we can also assume those numbers are probably a little bit higher.
All right, here's your next question. I am wondering how they attain the data about people having disabilities in the field. Do you think that there is some underreporting for fear of not being hired or treated well?
100%. So all of my stats are self-reported, which means we can assume most of my stats are underrepresentative of the actual numbers of people. Self-report is not the greatest way to collect data, but it's what we have.
All right. Which model of disability is best suited to meeting the needs of people who have psychotic conditions that includes the symptom of anosogeny? I'm not saying it right. I'm sorry about that. So that they are disabled from their illness or understand their need for treatment. And it's anosogny. Sorry.
And
Sorry about that.
anosognia. So they don't know that they have a psychotic condition. They are without knowledge.
Okay.
That is a fabulous question. And I think for this one, first of all, I totally believe in autonomy and having the person choose which of the models fits best. So I don't have a full answer for you. I think as a practitioner, one of the things you probably want to be thinking about is that functional model. What's going on for them and what can you do to give them some tools so that they can function better, which is really hard if they think they're functioning fine. I don't know how many of you saw Esme's presentation earlier today around her podcast, Lost Patients. Listen to that. I think that would give you some good ideas. It's a really amazing podcast. And I think when we're thinking about psychotic disorders, especially when somebody is psychotic enough, they don't understand that they're psychotic and having difficulties, it is really, really, really hard to treat. But that's where validating underlying feelings, validating their reported experiences, not the details of their experiences necessarily, right? We don't want to go around saying, yeah, that happened to you necessarily. But the felt experience of that, I think, is really, really important. And then I think it's really important to help them activate any social support networks that they have that can help keep eyes on them and help keep them safe as they will let us help them be.
All right. I think we have time just for a couple more. I hear things that are discruent. One is that asking about someone's disability is traumatizing and ableism. Another is that providing too much support is ableism, and not providing accommodations is ableism. How can one not be ableist?
First of all, I don't think asking questions about someone's disability is ableism. I would so much rather you come up to me and say, hey, do you need any help with that? Hey, tell me about what works and what doesn't for you, rather than assume I need help or assume I don't. It's the assumption in those questions that's the problem, not the questions themselves. And then working with someone collaboratively to figure out what accommodations you need. Hey, maybe I'm a teacher. Well, I am a teacher. And I see a student is struggling. And I say, hey, I'm noticing you're really struggling with this piece of the assignment or that thing in class. I'm wondering if you've ever thought about using this tool or trying this technique. I had a teacher, I struggled with math. I don't have a math learning disability, but I struggled with math. And my teacher said, why don't you take the test twice? And she gave me extra time on her own. I took the test once. I compared my answers when I took it a second time, right back to back, right in the same space. If the answer wasn't correct or if it didn't match, I did it over and over again until I got 2 matching answers in a row. I went from failing math to getting an A in math. And it was all about having some accommodation that I didn't even know I needed. So, but working collaboratively with your students about what will work and what won't work, you don't even necessarily need to know if they have an underlying something to provide those accommodations.
Thank you so much, Dr. Scriven. And now